Chapter 44 Nutritional Problems. Nutrition is the sum process by which one takes in and uses nutrients, and this can create different problems such as undernutrition, normal nutrition, and overnutrition. Normal nutrition would involve the ingestion of a balanced diet, getting macronutrients such as carbohydrates, fats, and proteins, along with micronutrients such as vitamins, minerals, and electrolytes. A convenient way to estimate the daily calories is based on kilocalories per kilogram. An average adult requires an estimated 20 to 35 calories per kilogram of body weight per day. Carbohydrates are our primary source of energy, providing 4 kcals per gram, and are classified as simple or complex, provide the chief protein-sparing ingredient, and compose 45 to 65% of our daily caloric needs, and should include 14 grams of fiber per 1,000 calories. Composing simple carbohydrates are monosaccharides such as glucose or fructose, or disaccharides such as sucrose, maltose, and lactose. On the other hand, complex carbohydrates contain polysaccharides, which are starches such as cereal grains or potatoes. Fats are our major source of energy, providing 9 kcals per gram. They're stored within the adipose tissue of the abdominal cavity, with carriers of essential fatty acids along with the fat-soluble vitamins we need to function. These should compose 20 to 35% of our total daily caloric intake. Keep in mind, though, that fats are potentially harmful, especially saturated fat and trans fats. For the healthier options, try to search out monosaturated and polysaturated fat, especially the heart-healthy polysaturated omega-3 fatty acids, such as in salmon. Proteins are required for tissue growth, repair, along with maintenance, and also help with body regulatory functions. They also help with energy production and provide 4 kcals per gram, and should compose 10% to 35% of your daily intake. Proteins, along with amino acids, are the fundamental units of protein structure. The body can synthesize non-essential amino acids, though it cannot synthesize 9 essential amino acids. These are obtained from animal and plant sources primarily, along with complete and incomplete proteins. Complete proteins are found in sources such as eggs, fish, meats, milk and dairy, and poultry, while incomplete proteins are primarily found in grains, legumes, nuts, and seeds. Vitamins are organic compounds required in small amounts for normal metabolism. They function primarily within enzyme reactions and are divided into 2 categories, the water-soluble and fat-soluble. Water-soluble are B and C vitamins, while the fat-soluble A, D, E, and K can be much harder for the body to excrete should you take in an abnormally high amount. Also, things like mineral salts, such as magnesium, iron, and calcium. They're necessary to build and repair tissues, and work to assist within various bodily functions, along with the major and trace minerals. Within our major minerals are the electrolytes that we previously discussed, such as calcium, chloride, magnesium, phosphorus, potassium, sodium, and even sulfur. Then you have your trace elements, such as chromium, copper, fluoride, iodine, iron, manganese, selenium, and zinc. Among the special diets you're sure to encounter out on the nursing floor would be vegetarians, who have the common element is exclusion of red meat from the diet, and they need a well-planned diet to avoid vitamin and protein deficiencies, particularly B vitamins and iron. Vegans, on the other hand, eat only plants, and lack that cobalamin, vitamin B, that's common within a meat-based diet, and can develop megaloblastic anemia along with neurologic signs of deficiency. On the other hand would be lacto-ovo vegetarians. They eat plants along with dairy and eggs, though watch for vitamin and mineral deficiencies, particularly iron deficiency in this case. For foods high in iron, first would be breads, cereals, and grains, such as farina and oatmeal, along with the meat, poultry, fish, and other alternatives such as beef liver, chicken and turkey liver, clams, oysters, pork liver, and soybeans. For culturally competent care, nurses should know the basics of your vegan diets, your religious diets, such as kosher diets. No one expects you to be an absolute expert at it, but knowing the basics and asking the patient what they prefer or what they need, getting them to the right resources to provide them adequate nutrition while they're there. promote healthy nutrition, teach and reinforce healthy eating habits. Assess the patient's nutritional status, and during your assessment of the patient's physical problems, include recommendations. Next up would be malnutrition. Malnutrition would be the deficit, excess, or imbalance within essential nutrients. For undernutrition, this is nutritional reserves that are depleted, with nutrient and energy intake not sufficient to meet their daily needs. On the other hand, would be overnutrition. This is ingestion of more food than is required. Starvation-related malnutrition is the primary protein caloric malnutrition, meaning their nutritional needs are not met through food intake. On the other hand, would be chronic disease-related malnutrition, and this is where the patient's nutritional needs are not met secondary to another illness, such as cancers, rheumatoid arthritis, or even obesity. For acute disease or injury-related malnutrition, this is related to acute disease, marked inflammatory response, secondary to major infections, burns, traumas, or surgery. Other factors to consider would be food insecurity. It's no secret that things are not going well in this country. Prices continue to rise with wages not really meeting that. And you look at food, especially the food banks here in Cleveland, those lines are getting longer and longer. Everything from safety net programs and government and local programs trying to pick up the slack, but unfortunately, things are not going in the right direction. Other contributing factors include illness, surgeries, injuries, and hospitalization. Also, GI diseases with symptoms that interfere with the normal food consumption and metabolism. Malabsorption syndrome may result from impaired absorption of nutrients within the GI tract. This could have many different causes, from decreases in enzymes, decreases in the bowel surface area, or even drug side effects. As far as incomplete diets, vitamin deficiencies are rare in most developed countries, and are usually found in those with alcohol use disorder in the case of B vitamins, drug use, chronic illness, or poor dietary practices. Drug nutrient interactions from malnutrition result from altered drug effectiveness, impaired nutritional status, and along with a combination and interactions with herbs and dietary supplements. As the starvation process begins, the body initially uses the carbohydrates in the form of glycogen from the liver and muscles to meet its metabolic needs. Unfortunately, these stores are minimal and may be depleted within 18 hours. From there, the body moves on to the skeletal proteins, which are converted to glucose for energy. These reserves allow the metabolic process to continue, and from prolonged starvation, 97% of the calories from fat and conserving proteins. These fat stores are used up in 4 to 6 weeks, though, depending on the amount available. Once the fat stores are used, the body uses visceral and body proteins to supplement it. As the process continues, liver function becomes impaired, while protein synthesis decreases. The plasma oncotic pressure also decreases, resulting in body fluid shifts from the vascular space into the interstitial compartment. Along with this, albumin leaks into that interstitial space, further contributing to the edema. On physical assessment, the patient's skin would appear dry and wrinkled. As the sodium-potassium pump fails, deficiencies in calories and proteins continue. The liver loses mass and becomes infiltrated with fat, and death will rapidly ensue if the patient does not receive the dietary protein necessary nutrients they need to survive. During the starvation process, there is a decrease in the body mass, a sparing of the skeletal muscle, and a decrease in protein breakdown. In inflammatory states, there are also changes in expression of the pro-inflammatory and anti-inflammatory cytokines. These cytokine changes may result in increased protein and skeletal muscle breakdown, increased glucose turnover, decreased negative acute phase proteins such as albumin and prealbumin production, and an increased positive acute phase protein C-reactive protein production. Malnutrition progresses from mild to emaciation to death. The skin, nails, and hair will begin to appear dry and brittle. Mouth and tongue, muscles, CNS changes, weakness, fatigue, and an increased susceptibility to infections, along with anemia. When assessing the patient, we should identify their food history for the past week, along with their height, weight, vital signs, and a thorough physical examination. For lab results, we should look at albumin, prealbumin, their C-reactive proteins, electrolyte levels, and a complete blood count, including hemoglobin and lymphocyte count. We could also use specialized assessment tools, such as the mini nutritional assessment or the minimum data set. Also, make sure to carefully look at changes in weight, their diet history, again, that height, body mass index, the physical examination, and an anthropometric measurements. By anthropometric measurements, we mean things like skin fold thickness, their mid-arm circumference, and compared that with standards for a healthy person of a similar size. For planning, our goals are that a patient with malnutrition will achieve an appropriate weight, consume a specific number of calories per day on an individualized diet, and have no adverse consequences related to the malnutrition or nutritional therapies. For malnutrition, there's other resources available, such as the MyPlate, Dietary Guidelines for Americans, or Nutritional Fact Food Labels. The acute care section within the textbook has other examples of high calorie, high protein foods that you could recommend to the patient. For our nursing implementation, we want to make everything from a daily calorie count, high protein, high calorie foods are available, provide multiple small feedings, in addition to supplements, appetite stimulants, a diet diary, dietary consult, and discharge instructions to maintain their progress. During our ongoing evaluation, the patient will achieve and maintain an optimal body weight, consume a well-balanced diet, experience no adverse outcomes related to malnutrition, and maintain that optimal physical functioning. The elderly are at a particularly high risk for malnutrition due to everything from oral cavities and dental decay, and as well as decreases in their digestion and motility, decreases in the endocrine system, musculoskeletal system, as well as vision and hearing issues. Next, let's talk about enteral nutrition. Enteral nutrition refers to tube feedings, core pack feedings, and is the administration of a nutritionally balanced liquefied food or formula through that NG tube. This method could be indicated for those with anorexia, orofacial fractures, head and neck cancers, and neurologic or psychiatric conditions. It could also be indicated for those with extensive burns, critical illnesses, chemotherapy, or radiation therapy. Shown in Figure 39-6 from the textbook is the nutritional support algorithm that provides the standards for nutritional support of an adult hospitalized patient. Enteral nutrition provides nutrients alone or supplements to oral or parenteral nutrition. It's easily administered, safer than parenteral nutrition, and is more physiologically effective than parenteral. It's also less expensive. There are a variety of formulas, including special formulas for patients with diabetes, liver issues, kidney, and lung disease. The delivery options include continuous infusion by bolus or by pump, bolus by gravity, or by syringe. The enteral feeding tube is usually made of polyurethane or silicone, making it soft and flexible. It is placed within the small intestine, though a stylet may be used to make it show up on imaging so they can ensure that it's in the right spot. Unfortunately, nasogastric and nasointestinal tubes can clog easily. They can also be dislodged by vomiting or coughing and can be knotted or kinked in the GI tract as well. Gastrostomy or jejunostomy tubes may be used when a patient requires tube feedings for an extended time. The patient must have an intact, unobstructed GI tract, and it can be placed surgically, radiologically, or endoscopically. On the other hand, percutaneous endoscopic gastrostomies, or PEG tubes, require esophageal lumen wide enough for an endoscope to pass through. PEG and radiographically placed gastrostomies have fewer risks than surgical placement, a lower cost, and minimum sedation. Using endoscopy, a gastrostomy tube is inserted through the esophagus into the stomach and is then pulled through a stab wound made within the abdominal wall. The feedings can be started when bowel sounds return, usually within 24 hours after placement, and most PEG tube feedings can start within 4 hours of insertion. Tube feeding does come with a high aspiration risk. We always want to make sure the tube is in the right position and that we've maintained the head of the bed in the high Fowler's position. Also, follow your agency's policies regarding checking the gastric residual volume. By this, they mean in some places it may be necessary to pull back with a syringe on the NG tube and assess the stomach contents for any residual feeding before we provide the patient another feeding. This is to ensure that they've digested the previous one. The patient should be positioned in the sitting or lying at the head of the bed at a 30 to 45 degree angle. The head of the bed remains elevated for 30 to 60 minutes after for intermittent delivery. The tube position is confirmed with an X-ray, and mark the exit side of the tube. Make sure to check that placement for each tube feeding and administration or every 8 hours with continuous feeds. Also, check the insertion length regularly. The tube position determines by the method used to check placement, along with the aspiration of stomach contents, checking the pH to confirm that we're getting stomach acid, and confirming the placement with more than one test. We want to be absolutely sure it is in the right place. We also want to assess the skin around the tube daily, along with monitoring for bump retention, applying a dressing until the site is healed, and after healed, wash with soap and water regularly, along with a protective ointment or barrier cream to further protect it. We also want to regularly ensure tube patency. Flush the feeding tube with 30 milliliters of water for continuous tube feedings to keep it flushed out, keep it clear. We also want to flush with water before and after each bolus feeding, and as well as continuous feeding administration on a feeding pump with an occlusion alarm to notify us if a blockage is occurring. In the case of a misconnection or an inadvertent connection between an enteral feeding system and a non-enteral feeding system, such as an IV line, peritoneal dialysis catheter, or a tracheostomy tube, we want to stop it immediately. This is going to be a severe patient injury or death that can result. Be very, very careful. I would be surprised if they would even... I'm not sure how you could make that mistake, but it has happened. For our general nursing considerations, daily weights, assessing for bowel sounds before feeding, accurate I's and O's, initial glucose checks, labeling the bag with a date and time it started, as well as tubing change every Q24 hours. Other complications can include vomiting, dehydration, diarrhea, or constipation. Gastrostomy or jejudostomy feedings have two potential problems: skin irritation and the pulling out of the tube. Teach the patient and family about feeding administration, tube care, and to be very careful with it to prevent complications. Keep in mind with the elderly that they're more vulnerable to fluid and electrolyte balances, glucose intolerance, a decreased ability to handle large volumes, and an increased risk of aspiration. Next would be parenteral nutrition, or TPN. Parenteral nutrition is the administration of nutrients directly to the bloodstream. This is IV nutrition. Common indications include chronic severe diarrhea and vomiting, complicated surgeries or traumas, GI obstruction, GI tract abnormalities or fistulas, intractable diarrhea, severe anorexia, severe malabsorption, or short bowel syndrome. This is a last resort when the patient cannot receive their nutrition entirely by mouth. It is composed of a base solution containing dextrose and a protein in the form of amino acids. It also has a set prescribed electrolytes, vitamins, and trace elements added to the mixture. The calories are supplied by carbohydrates in the form of dextrose and by fat in the form of fat emulsion. Calories are supplied by up to 30% of the total amount from fat, also available in 10, 20, and 30% solutions. These provide a large number of calories in a small amount of fluid. The critically ill may receive less, however. Protein is also divided in at a rate of 1 to 1.5 grams per kilogram per day, though the requirements are increased in nutritionally depleted patients to ensure a strong nitrogen balance. Electrolytes are provided on an individualized basis and also include trace elements and vitamins such as zinc, copper, chromium, manganese, selenium, iodine, as well as multivitamins as needed. The methods of administration include a central parenteral nutrition, going to be peripheral IV to a more likely a central line for long-term cases. Peripheral parenteral nutrition, just as it sounds, is the providal of that parenteral nutrition through a peripheral IV line. It's used for short-term nutritional support and can provide protein and caloric requirements, though not as high as TPN. In the case of TPN, these is through a central and peripheral nutrition differ in tonicity. Central solutions are hypertonic and require a large central vein that can handle high glucose content, ranging from 20 to 50%. On the other hand, peripheral solutions are less hypertonic, because a peripheral vein can only handle glucose up to 20%. These solutions are prepared by a pharmacist or a trained technician under strict aseptic techniques. The central catheter is placed under sterile conditions by a physician or advanced practice nurse. The site is then covered with a sterile dressing you as the bedside nurse need to be assessing very closely to be watching for the earliest signs of infection. Complications of parenteral nutrition could also include that refeeding syndrome we talked about with anorexia. In this case, the body is suddenly inundated with hypertonic solution, has much more protein than it has used to, has much more solutes, and that causes a major fluid shift. Other complications of PN include metabolic problems such as altered renal function, essential fatty acid deficiency, hyperglycemia, hypoglycemia, hyperlipidemia, and liver dysfunction. Patients are also at increased risk for an air embolus, catheter-related sepsis, dislodgement, thrombosis of vein phlebitis, hemorrhage, occlusion, pneumothorax, hemothorax, or hydrothorax. Patients on parenteral nutrition are also going to be assessed very closely. Everything from regular vital signs every 4 to 8 hours, along with that blood glucose checking being critical. They're going to check initially every 4 to 6 hours. And because again, you got to think these patients are not getting their glucose from a normal diet like you or me. They're getting their glucose, their sugars that they need, straight into their bloodstream. And this can cause much more wild shifts than you would expect, even for a patient that's not diabetic. We also want to monitor the lab values, including electrolytes, BUN, CBC, also dressing changes with the CITER observations, and also watching for those fluid shifts and refeeding syndrome closely. Before starting PN, check and label the ingredients against the order. At the Cleveland Clinic, our protocol was that it was double signed by 2 different nurses to make sure we're absolutely sure they are getting the prescribed composition of their TPN. Also, examine that bag for signs of contamination, any floating particles, and discontinue the PN solution at the end of the 24 hours. Also, make sure to check change those tubings every 24 hours, and it's going to include a filtered line as well to make sure no particles accidentally get through. Watch for infection and septicemia very closely as well, starting with local manifestations such as redness, tenderness, or exudate at the catheter insertion site, as well as systemic manifestations like fever, chills, nausea, vomiting, or malaise. Don't forget to get blood and catheter cultures if any infection is suspected. We want to identify this early and catch it as quickly as we can. In the case of home nutritional support, make sure we're teaching the patient and caregiver about proper catheter and tube care, along with mixing and handling the solutions and tubing properly. But anyway, that's all we got for this chapter. I'll see you in the next slides.